Hi, I am Dr. Giridhar, and I will be talking to you on current treatment modalities or current treatment patterns for polypoidal choroidal vasculopathy. So I'll just share my screen now. So PCV current management principles. So over the last decade, there has been a lot of development as far as the understanding of polypoidal choroidal vasculopathy is concerned, and also in the principles of management. Today, PCV is part of the pachychoroid spectrum, and it is otherwise called aneurysmal type 1 neovascularization. This is a new terminology that has been given by the pachychoroid interest group, wherein they describe the type 1 neovascular membrane, which finally progresses to create polypoidal endings at the tips of this neovascular network, and this possibly results in this condition called polypoidal choroidal vasculopathy. Therefore, we are not sure whether it's a natural progress from pachychoroid pigment epitheliopathy to pachychoroid neovasculopathy to polypoid disease. And most important, although PCV has been associated in the pachychoroid spectrum, PCV can be associated with a thin choroid in a small number of patients. Therefore, we looked into the fellow eyes of patients with active PCV, and we found that some of these eyes had a flat, elongated pigment epithelial detachment, and this flat, elongated epithelial detachment progressed to active neovascularization in about 11 of these eyes over a period of 17 months. And by following up these patients, we have realized that possibly a pachychoroid pigment epitheliopathy can progress to a pachychoroid neovasculopathy and subsequently a polypoidal disease. Now, if you see the ICG angiography taken at different times over a period of 1.5 years, here you can see there is just a type 1 neovascular network. Here, the same has progressed to small polypoidal lesions, which has further progressed over a period of time, resulting in an active disease. Therefore, it is possible that patients with pachychoroid spectrum slowly progress from a type 1 neovascular membrane to a polypoidal disease. This is again the same picture of the same ICG pictures of the same patient, again to just show you the natural progress from a PCN to a PCV over a period of 1.5 years. Although ICG angiography is the gold standard as far as the diagnosis of PCV is concerned, we now know that there are very classic biomarkers in spectral domain, OCT, which is a diagnostic of PCV. Therefore, in centers where ICG is not available, possibly a good is the OCT taken at various levels in the macula with multiple cuts can diagnose this particular clinical condition. So what are these features? One is what we call as a tall peaked PED. Second is a notched PED, as you can see here, and also a nice bumpy pigment epithelial detachment. But most important finding which we have seen is what we call as the double layered sign, which I'll be explaining to you in greater detail. Now, if you see this particular photograph, this looks more like a central serous chorioretinopathy with some element of fluid in the macula. And then if you see very carefully, you see these orangish reddish elevation here. And if you pass the OCT through those areas, you see this typical notch PED and the serous macular detachment, which is classic of a polypoidal disease. So the double layer sign is a very important feature, and we followed. I mean, we examined the OCT in 109 consecutive eyes in the pachychoroid spectrum, which involves patients with PPV, PCN, PCV, and CSCR, and we found that both in PCV and in PCN, nearly more than 90% of these eyes had a double layered sign. So the double layered sign is basically a separation of the retinal pigment epithelium from the Bruch's membrane. And in patients with a polypoidal disease, this space is always hyper-reflective. The DLS is also seen in central serous chorioretinopathy, but in central serous chorioretinopathy, this is a hypo-reflective space. And moreover, the DLS or the double layered sign is much shorter in patients with CSCR when compared to what we see in polypoidal disease or in pachychoroid neovasculopathy. Another important finding is that if you do if you do the ST-OCT and pass it through the whole area of the DLS, you will find that there is a neovascular network which is grown between the Bruch's membrane and the retinal pigment epithelium. So characteristically, in patients with polypoidal disease, the area of the the area of the double layered sign involves the presence of the neovascular network, and these neovascular network ends in polypoidal dilatation that results in this pigment epithelial detachment. So a very characteristic feature in ST-OCT, which again has been described in this particular article very well. Coming to the treatment strategies in polypoidal choroidal vasculopathy, today we know that the choice of treatment lies between a combination therapy using verteporfin PDT and anti-VEGF injections versus monotherapy with anti-VEGF injections. I put the thermal laser in a different color because we use thermal laser for extrafoveal PCV. But personally, today, I feel that the role of thermal laser in PCV is very limited because we know that the polypoidal disease is basically a vascular network ending in polyps. And therefore, unless and until we destroy the vascular network along with the polyps, the disease is not going to be treated properly. And therefore, if you're using a thermal laser, even in cases of extrafoveal lesions, if this neovascular network is quite large, you need to create a large scotoma or a large area of laser treatment, which can do some degree of harm. Therefore, thermal laser probably can be limited for small neovascular tufts along with polypoidal disease, quite far away from the fovea. Therefore, to discuss about both the combination therapy and the monotherapy with anti-VEGF and what is the current understanding and application of these two treatments, we need to understand two important randomized trials. One is the Everest-2 trial, the data of which was recently published in JAMA, wherein in the Everest-2 compared monotherapy with ranibizumab and combination therapy using PDT and ranibizumab treatment. And if you see the results of the Everest trial, what are the various results of the Everest trial, gives us an understanding as to the basic behavior of this disease. So there were 332 patients which were randomized to combination therapy and monotherapy with ranibizumab, and 41 of these eyes in monotherapy were switched to combination therapy during the course of the RCT trial. So if you look at the mean BCVA improvement, you see that combination therapy has given a better outcome, visual outcome when compared to monotherapy with anti-VEGF. However, we should understand that both forms of treatment did result in improvement of the visual acuity. So I would like to just summarize the Everest 2 results and also just say a few words as to how we can apply the results of the Everest 2 trial in our clinical practice. So based on in the Everest trial, actually, the 27% of the participants had disease activity in the combination group versus 57.5% in the monotherapy at 24 months follow-up. This is a very important information. Second important information is that the mean number of injections in the monotherapy was 12.5, and the mean number of PDT for patients who were in the combination therapy was just 2.2 over a period of 24 months. 44.6% of the patients received only one cycle of PDT in 24 months, and only 33% of participants in the ranibizumab group showed polyp regression. Therefore, if you look at the Everest trial, it looks like the combination therapy is superior to monotherapy with anti-VEGF. It reduces the need for a large number of anti-VEGF injections, and it does give us a period of quiescent disease. So that is the basic comparison of ranibizumab monotherapy versus combination therapy with PDT. The second important study which I would like to look into is the PLANET study, because the PLANET study used intravitreal aflibercept, and basically now we know that aflibercept is a more effective anti-VEGF agent in the treatment of polypoidal choroidal vasculopathy. Now, if you look at the study design in the PLANET study, patients received 3 monthly injections of aflibercept, and after that they were randomized into 2 groups. One is monotherapy with aflibercept, where they received aflibercept every 8 weeks, and the other group also was monotherapy with aflibercept, but they underwent rescue PDT if they fulfilled criteria for rescue treatment with PDT. Now, what were the criteria for rescue treatment? The criteria for rescue treatment were: 1, the only eyes with a visual acuity of 20 by 40 or less were included in the study. And if the visual acuity after the initial loading dose of aflibercept shows only a less than 5 ETDRS letter gain, or it is between 5 and 10, and the investigator at his discretion uses PDT. At the end of 3 months of injection, there is evidence of persistent fluid or the appearance of new fluid at the end of 3 months. And also at this point of time, ICG angiography shows active polypoidal lesions, then the patient can be considered for rescue treatment with PDT. Now, if you look into the results of this particular study, we know that both the patients with the monotherapy with aflibercept did extremely well, and the number of eyes that required rescue PDT were very, very small in number. Therefore, in an RCT trial where Eylea or aflibercept was given practically at 8-week interval over a period of 52 weeks, it was shown that it was quite effective both in terms of polyp regression and also in a resolution of fluid and hemorrhage in the macula. And the need for rescue treatment with PDT was very small in number. So what we need to understand is that if we are able to give Eylea on a very regular interval with monotherapy, we may be able to achieve good results, but the challenge remains that these patients will need very frequent intravitreal injections, for which we need to decide whether our patients will be compliant. So, concluding the PLANET trial, monotherapy with aflibercept was non-inferior at the primary endpoint of 52 weeks in terms of both visual acuity improvement and also in improvement in the morphological changes using SD-OCT. So based on these 2 trials, I would like to discuss a couple of cases, and with that we can make some conclusions as far as our understanding of the treatment of PCV is concerned in the year 2020. So this is the first case of mine. This is a 56-year-old lady. Actually, she had bilateral disease, but I'm just going to show you one eye, the right eye. The right eye, actually, if you see here, she's got a macular determinant. This is the color photography, and she does have some pachytrusion-like picture in the temporal portion, and she has suspicious fluid also in the macula. You do the OCT, it shows the characteristic features, including this pigment epithelial detachment. An ICG angiography shows a small polypoid lesion surrounding by an area of hypofluorescence, which is very, very characteristic. Therefore, this patient has got very early disease, and this patient, I'm going to a long history over a period of time, very early disease. And if you see the patient, therefore, I put her on monotherapy with ranibizumab. At that period of time, we did not have aflibercept, and probably if aflibercept was available, I might have tried that at that period of time. But nonetheless, the reason why I suggested monotherapy in this patient and not combination therapy was because of the presence of very good visual acuity and this very small network that we are seeing in ICG angiography. So I gave her multiple injections of ranibizumab, but unfortunately this patient was a poor responder, and that is what we normally see in many of these eyes with PCV who are either treated with bevacizumab or ranibizumab. And even after 5 injections, the patient was coming back with recurrent fluid. And if you see the serial ICG angiography before we started and after about 5 injections over a period of 1 year, there is an increase in the size of the network. At this period of time, we switched the patient to reduced fluence photodynamic therapy with intravitreal anti-VEGF injection. And you can see here there was a very good response to the treatment. Visual acuity continued to be the same after treatment. The fluid had disappeared. And this patient and the ICG angiography done following the treatment with PDT shows complete regression of the polyps, but there is still a small neovascular network that's remaining. That's usually seen. The network never completely goes, but the network in this particular case is not leaking in the angiography, and therefore there is no activity. So this patient has been coming to us on a very regular follow-up, and after a period up to about 42 months, the patient did have a quiescent period of up to 42 months that really works for more than 3 years. Therefore, the take-home information as far as this particular case is concerned is that number one is that some of these anti-VEGF agents need to be injected very frequently in cases of polypoidal disease, and therefore the question of compliance and patient satisfaction becomes questionable. Number two is that if you do a combination therapy with PDT, you may get a quiescent period of about 1.5 to 2 years. And this is what we need to explain to our patient when we advise combination therapy in some of these patients with polypoidal choroidal vasculopathy. Therefore, based on this particular case, we did a long-term, we published a paper on the long-term efficacy and safety of Gerthoff and PDT with anti-VEGF agents in PCV. And the basic purpose of this particular paper is to answer one crucial question: how does PDT differ or benefit patients with PCV, and what is it different from monotherapy with anti-VEGF agents? So if you look into our cases of 42 eyes of 40 patients, the most important take-home message is there's a long follow-up. The median follow-up is 38 months. The range was 12 to 71 months. And we only picked up eyes with good visual acuity, that is visual acuity of 20/60 or better. And the reason why we did that is, number one, to see whether there are any complications of PDT and whether PDT results in worsening of visual acuity. So the most important take-home message information from this particular study was that nearly 42.5% of the eyes showed no recurrence of fluid on SD-OCT till the last visit, with a mean follow-up of 27 months. So this is the most important take-home message, that PDT combination therapy does give us, in at least in half the patients whom we treat, up to 2 years of quiescence or no treatment, no injections, etc. And most patients do not show any drop in visual acuity as a result of the treatment. So this is another case here from the series. Here you can see this is again a patient with a peripapillary polypoidal disease. The patient was initially treated with injection ranibizumab, and you can see a large cluster of polyp even after the injections. And finally, the patient underwent a full fluence PDT. And the reason why we give a full fluence PDT in this particular case is basically because of the large cluster of polyps. Because the size of the lesion is quite large, the disease is more active when you compare to the first case, which was practically subfoveal. And here again, you can see the patient was quiescent for exactly 2 years after treatment. The patient received a retreatment at that period of time. And again, after the retreatment, the patient was quiescent for another 2 years. Therefore, the take-home message is that polypoidal disease is a chronic disease with periodic exacerbations and remissions. And most of these patients will need proper long-term follow-up to detect early recurrence and treat them accordingly. So this is my third case. Now, this is a patient who was treated purely on monotherapy. Now, the reason why this patient was treated on monotherapy is because of two particular purposes. One is this patient was a one-eyed patient. The other eye had a large macular scar, and this eye was a very good eye. And the patient was compliant to regular follow-up, and the patient could afford periodic anti-VEGF injections. And these are some of the important information we need to extract from patients before we subject them to any form of treatment, because compliance and patient affordability, etc., becomes crucial in management of some of these patients. So this patient was initially many years ago put on ranibizumab, but with ranibizumab, he required an injection practically every month. So once we had aflibercept coming into the Indian scenario, we shifted this patient to aflibercept, and slowly with aflibercept, I could get a good response to the treatment. And after 5 years of follow-up, the patient still maintained good visual acuity of 6/9 N6, and I finally shifted him to a treat and extend aflibercept, wherein I was able to get a dry macula up to 8 weeks. So every 8 weeks, he used to get an injection of aflibercept. Patient maintained good visual acuity. Therefore, the take-home message or the information that I can give from this particular case is that monotherapy with anti-VEGF is definitely effective in polypoidal choroidal vasculopathy. The only challenge is that patients have to be kept at very close, regular follow-up, and periodic injections, up to 4 to 5 injections per year, may be necessary in a substantial number of patients to maintain visual acuity and to keep a dry macula. So, in summary, combination treatment results in greater polyp regression, and you can achieve a drug treatment-free period of up to 2 years and at least 50% BIs, lesser number of anti-VEGF injections, but the challenges of the availability of Visalign and the availability of PDT laser. So I may suggest PDT combination therapy in certain clinical situations. Number one, if I find not a very large network, but a reasonably large network, which is subfoveal, and for which the patient already has a drop in visual acuity to either 618 or 612, and the patient has been understood and educated about this particular treatment, I may suggest this as the first line of treatment in polypoidal disease. However, if I have a patient with a very small polyp lesion, a very good near normal visual acuity with minimal fluid, I may start this patient on a monotherapy with anti-VEGF treatment. So anti-VEGF monotherapy is comparable to PDT OCT-based response. It is effective for visual improvement. However, as I had told you earlier, frequent injections. It's important to remember that it's ideal for eyes with submacular hemorrhage, and especially in eyes with thin choroid, probably there's a relative contraindication for photodynamic therapy because it can do harm. If we are contemplating anti-VEGF monotherapy, aflibercept probably is the ideal anti-VEGF agent with better response and polyp regression. I would like to say one last word about what I call as the rescue PDT. This is something that we have worked on, rescue PDT combination therapy. Very important in eyes which are poor responders to anti-VEGF injection, as I have shown at least two of my patients in this particular presentation. Thank you all for your kind attention.